Hi, I'm Dr. Laurel Benson. I'm a pediatric orthopedic surgeon at Rocky Mountain Hospital for Children in Denver. Today I'd like to talk to you about hip dysplasia and how it affects infants. Hip dysplasia is a silent destructive process. In infancy and childhood, it's absolutely painless, but the damage to the joint is ongoing. The child can walk and crawl on a normal schedule of milestones, but once pain begins to plague the child in adolescence, the surfaces of the hip are beyond repair. The cartilage is thinned and frayed. The degree of arthritis that we see is similar to that seen in many elderly patients. Unfortunately, for some older teens and young adults, the process is so destructive that hip replacement surgery in the early 20s is their final outcome. The surgical procedures that are used to try to salvage the damaged hip in the interim are major procedures with long recoveries. It's not something that any parent would want for their child. In the past, we worried most about babies who were born breech or who were in utero for extended periods of time in the breech position. But recent research conducted at the Naval Hospital in San Diego, California, revealed that even a short period of breech positioning puts some infants at risk for dysplasia. Female babies, firstborns, and infants with a family history of dysplasia are also at risk. Of all these risk factors, breech position seems to be the most predictive of hip dysplasia. Knowing that the infant was in the breech position, even temporarily, gives the healthcare provider the best information possible. The goal of treatment in hip dysplasia is to position the legs and the body in a brace or harness so that the femoral head is aimed at the center of the acetabulum. Pressure there influences the socket to grow in the center to create a deeper cup for that femoral head. Since infants grow at such a fast rate, the sooner that treatment can begin, the better the outcome. Hip dysplasia that's recognized and treated in infancy can have a marvelous success, with 95% of patients achieving a normal hip. So in closing, I'd like for you to remember these points. Hip dysplasia isn't painful, but the damage can be significant, and detecting that problem early on is so important. The 4 F's to remember are feet up, breech presentation, female, firstborn, and family history. They're great guideposts to assess the risk factors for the baby. Early detection produces better results. 95% of patients who are treated in infancy have normal hips. On physical exam, one of the best, simplest tests is to determine whether there's any limitation to hip abduction. It really can be a trigger to let you know whether further action is required. Part of treating hip dysplasia is using ultrasound images of the baby's hips because cartilage and bone in infancy are difficult to determine. But on ultrasound, we can see the cartilage shapes and the relationships that the ball and the socket have together. This will guide not only treatment options, but our way of assessing how the child is responding. If you have any questions, any concerns, we'd love to see you here. When treated early, children with hip dysplasia can lead normal lives. We want you to know about this, follow these guidelines, and let us be at your side to get your child up and going on the road to get up and go. Thank you.